Today we will be discussing diseases of the aorta. In this presentation, our main focus of attention would be on aortic aneurysm and aortic dissection. In this presentation, we will not be discussing aortosyphilitic aortitis and Takayasu disease. By definition, aortic aneurysm is pathological dilatation of the aorta, which is 1.5 times more than the adjacent proximal normal segment. And this condition is mainly due to medial degeneration and also degeneration of elastic fibers of the aortic wall, and it may involve one segment or several segments of aorta. Uh, the aortic aneurysms are fusiform in shape or they are secular in shape. You can see in the top picture there's a secular aneurysm of the aorta above the origin of renal artery, and in the middle you find a fusiform aneurysm of abdominal aorta below the origin of renal artery. And then in the bottom there's a picture which shows pseudoaneurysm. Pseudoaneurysm is a condition in which there is rupture of the wall of the aorta, and then there's a formation of hematoma which is then covered by the aortic, the wall of the aorta, which is adventitia, of course. Aneurysm may involve ascending aortic segment, they may involve descending thoracic aorta, or they may involve abdominal aorta, in which case it is the aneurysm is below the origin of the renal artery most of the time, or it may involve one of the branches of the uh, aorta, as is seen in the right picture. Abdominal aortic aneurysm is most common aneurysm, and 75% of the aneurysms of abdominal aorta are below the origin of the renal arteries, and the commonest cause of this condition is atherosclerotic disease of the aorta. The risk factors include smoking, old age, male sex, hypertension, and dyslipidemias. However, due to these risk factors, there is chronic inflammation of the wall of the aorta. There's release of metalloproteinases, and they lead to destruction of the collagen and median elastin of aorta and will lead to subsequent dilatation. Abdominal aortic aneurysms are usually asymptomatic, and by definition, the significant abdominal aortic aneurysm is more than 3 centimeter in diameter. And when you palpate abdomen, you may find a pulsatile abdominal mass, or some patient may come to you with vague abdominal pain radiating to back. But if there is sudden severe pain in the abdomen radiating to back, this may suggest there is rupture of uh, abdominal aortic aneurysm, which is emergency, and the patient must immediately report to hospital. And then, because the aortic segment is dilated, there is stasis within the aortic segment, and then it may lead to thrombi formation and with subsequent embolic phenomena. Thoracic Aortic aneurysms are usually associated with Marfan syndrome. I will show what Marfan syndrome is, but this is a condition in which the patients have some chest deformities, they have kyphoscoliosis, they have got a long stature, and the fingers are again long, and the fingers are hyper extensible, and then they have aortic disease in the form of dilated aortic root by cuspid aortic valve and mitral valve prolapse. And then there is syndrome which is called uh, Ehlers-Danlos syndrome, in which the skin is hyperelastic, and again, these patients have got some weakness of the media as well collagen and elastic fiber in the aorta, and they prone them to the dissection. The other conditions which are associated with thoracic aortic aneurysm are Turner syndrome, bicuspid aortic valve, coarctation of aorta, syphilitic aortitis, and then atherosclerosis. On the left side, you see a patient with different features of Marfan syndrome, long fingers and toes, and kyphosis, and then back and chest deformities. And on the right side, you can see a patient with Ehlers-Danlos syndrome. The skin is hyperelastic and the fingers are hyperflexible. Both these conditions are associated with the aneurysm of uh, ascending aorta. Thoracic aortic aneurysm, they may be asymptomatic or they may present with superior vena cava syndrome. Patient may feel dysphagia and hoarseness because of compression due to the aneurysm. There may be aortic regurgitation. A patient may present with acute coronary syndrome because of the involvement of the coronary ostia, or they may present with thromboembolic phenomena. And we will discuss aortic dissection in next few minutes. That is also a complication of thoracic aortic aneurysm. Diagnostic workup, on the right side you see X-ray chest with this dilated ascending aorta, dilated aortic root, and on the left side the echo shows again dilated aortic root. So both X-ray and echo are helpful in diagnosing uh, aneurysm of aorta. Then comes CT and MRI. On the left side you see the aneurysm of abdominal aorta below the renal arteries on CT angiogram, and on the right side MRI shows the aneurysm of the ascending aorta, uh, nicely, nicely shown on the right side. These patients, we should prescribe them beta blockers because beta blockers they decrease the force of myocardial contraction, they decrease the pressure generated by the ventricle. So they may slow the rate of aneurysm expansion, and they also protect the patient against development of aortic dissection. The blood pressure must be controlled with ACE inhibitors or ARBs. The patient must stop smoking. You should prescribe them statin in high doses, and you must follow them um, uh, after every year with serial echogram to see the progression in dilatation of the aortic root. This is very important. The follow up is very important. The surgical indication replacement of the aortic root with the graft is the aortic root size more than 5.5 centimeters or serial increase in size of more than 1 centimeter per year. Or if the patient is having bicuspid aortic valve with aneurysm, or Marfan syndrome with ascending aortic aneurysm, immediate surgical uh, treatment is recommended. You can see nicely in this picture on the left side a repair of ascending aortic aneurysm, in the middle repair of descending aortic aneurysm, and on the right side a repair of abdominal aortic aneurysm uh, with surgery. And you can see that on the right side the coronary arteries are nicely implanted in the graft after surgery. Uh, this procedure can be done by open surgery or by endovascular uh, graft insertion can also be done by after cardiac by performing cardiac catheterization. Aortic dissection is actually tear in the intima. The aorta is diseased. The wall is also weak because of loss of collagen and elastic fiber, and because of the shear stress on the wall of the aorta, there is tear in the intima, and then the blood dissects through the media and form a false tumor. And then it progress and keep on progressing and involving the osteo of the branches of the aorta, or it may progress proximally, may involve the coronary ostia or the pericardium, leading to various complications. So there is splitting of the aortic wall within media, which then propagates. There is another theory that the rupture of vasa vasorum lead to intramural hematoma formation, which then lead to a subsequent intimal tear. But mainly, I think it's the high blood pressure and weak intima which is responsible for the formation of aortic hematoma and the subsequent propagation of aortic dissection. You can see on the right side the blood flow. You can see the intima, media, and then adventitia. On the left side, you can see there's a picture showing normal vessel, and then there's a tear, and with a small error going through the false lumen, which is dissection, and the big arrow is going through the normal lumen. So there are two lumini of the aorta. Outside is the false lumen, and inside is the true lumen. And then on the bottom right side, the other theory comes in that there is rupture of vasa vasorum of aorta, the formation of intramural hematoma, and then it ruptures and into the aortic lumen and lead to dissection. So there are two mechanisms of aortic dissection nicely described in this slide. Aortic dissection is classified according to which part of the aortic segment is involved. Type A mm, uh, aortic dissection is when ascending aorta is always involved. We call it type A dissection. And type B dissection is when descending aorta is involved. So Stanford classification say if ascending aorta is involved, the patient is having type A aortic dissection, and if descending aorta is involved, patient is having type B aortic dissection. And there is other classification, type 1, the involvement of ascending aorta as well as descending aorta. Type 2, involvement of only ascending aorta. And type 3, involvement of only descending aorta. The type 3 are further classified into the type 3A and type 3B according to the involvement of the length of the aorta. So we have discussed the predisposing factors in aortic dissection. Marfan syndrome we discussed Ehlers-Danlos syndrome, hypertension, atherosclerotic disease, coarctation of aorta, bicuspid aortic valve in pregnancy, but hypertension and degeneration of the aortic valve, plus Marfan and Ehlers-Danlos syndrome and atherosclerosis main factor which predispose to aortic dissection. The patient with aortic dissection presents to you with severe chest pain, mainly retrosternal, and patient use the word that's word of stabbing, sharp object pushed into the chest, severe chest pain, which rises quickly to the peak and is persistent. This pain may remain retrosternal, may radiate to neck, uh, or may radiate to back when the dissection goes along the arch of the aorta to the descending aorta. And this pain is very severe and is not relieved by sublingual nitrates. So chest pain we have discussed. Then you examine the patient. The pulses may be normal, but pulses deficit may be present. Meaning if the dissection uh, flap closes the ostium of the vessel which is originating from the aorta, then that pulse will be lost. So pulses may be absent because of the involvement of the ostia of the uh, main vessels originating from the aorta. The patient may present with syncope. The patient may present with stroke because of the involvement of the carotid vessels, or patient may present with paraplegia because of the involvement of the anterior spinal vessels in the dissection process. So focal neurological deficit, if the dissection progresses proximally, there may be involvement of the ostia of the coronary artery causing acute myocardial infarction, usually inferior myocardial infarction, extending to the pericardium, may lead to cardiac tamponade, and then patient may develop acute left ventricular failure because of the acute aortic regurgitation. So these are very important complications of aortic dissection. ECG shows left ventricular hypertrophy and sinus tachycardia sometimes, and on XHS you can see dilated aorta in most of the cases. You can see nicely on the left side dilated aorta in a case of aortic dissection. Echocardiogram shows nicely the dissection flap in the aorta, uh, uh, transthoracic or transesophageal echocardiogram. Both are very specific for the diagnosis of aortic dissection and picking up of dissection flap. CT angio nicely shows dissection flap, and so is the MRA. You can nicely see the straight uh, line on the right side of the right side of the picture, the descending aorta, rightmost picture, and on the left side, the CT angio, you can see a gray line straight. This is the dissection flap, and in the middle, the dissection flap is also shown by arrow. You must admit your patient and then control the blood pressure. It's very important to give your patient intravenous beta blockers and sodium nitroprusside together. Intravenous beta blocker slow down the heart rate, and then it decreases the force of myocardial contraction and reduces the stress on the wall of the aorta. So it's very important immediately start intravenous beta blockers in the form of esmolol, labetalol, which is alpha and beta blocker, or metoprolol. And if the beta blockers are contraindicated, you can use intravenous verapamil or diltiazem. Uh, the blood pressure is not controlled. You can combine IV nitroprusside with beta blockers, but if you give nitroprusside alone, it will cause tachycardia and will put further stress on the wall of the aorta. So first beta blockers or verapamil, and then sodium nitroprusside. And then of course you manage the complications accordingly, like cardiac tamponade, you have to aspirate pericardial fluid, and then acute AR, again immediate hospitalization and treatment of pulmonary edema, and so you have to manage the situation according to the complication which your patient is having. Urgent surgical treatment is recommended in dissection involving the ascending aorta. So always type A dissection, urgent surgical involvement is very important. If the patient presents to you with organ ischemia, again surgery needed. And if the patient is having dissection with Marfan syndrome, urgent surgery is needed. But if the dissection is involving the descending aorta, you can wait, you can treat your patient medically because there are less chances of complication in this patient. So these are the different type of surgical procedure. On the right side, the ascending aorta repaired. On the left side, the descending aorta repaired. So this was all about aortic disease, the aneurysms and dissections. And then we are left with the last lecture of this series, and we'll discuss the tumors of the heart. Thank you very much.